So next up we have another insight session with Nick Howlett, who's Senior Data Science at NHS Bristol, North Somerset and South Gloucestershire ICB. This will be what looks to be another stimulating presentation on a study that's been done on A&E crowding and the impacts of medical patient boarding. Just a reminder again, there will be a chance for Q&A at the end, so please use the Q&A function. And I'll now hand you over to Nick for the presentation.
Thanks, James. Hi, yeah, so I'm Nick. Good morning, everyone. So yes, thanks for the introduction. So I work in Bristol as a data scientist, and I work under Rich Wood in the modelling analytics team at the ICB there. And this work was also performed in collaboration with clinical supervision from James Cameron. And yeah, so I'm going to talk about delay-related harm, which is a topic that has been, a term at least, that's been around for a while. So you might have heard of it. I'm going to introduce it slightly. I'm not going to introduce it in a chronological sense. I actually think I'm going to start with a headline. So this is from The Guardian, I think in April last year. And this headline is telling us that England A&E wait times led to needless deaths of up to 14,000. So that's an annual figure, and it's obviously very shocking and quite distressing. But I want to do this sort of analytical thing here and park away the kind of emotional human reflection on this and actually celebrate this headline because I think that it's a great example of very good scientific communication in just a handful of words, a huge amount of effort behind the scenes in terms of model construction and problem solving and data sourcing. I can tell you it's a multi-year national data study that led to this statement, and it can boil this down into this really sort of terse impact statement. And I think that's really cool. And I think that kind of it offers for everybody something. I think if you are a layman or someone that's not in healthcare or not analytically minded, you can read this and you can kind of get a sense of what it's saying. However, I think for the statisticians in the room, which I'm sure I'm joined by many, we want to learn, we want to know more. We want to know about how the sausage is made. So I'm going to talk about how this is done, which is essentially via statistical modelling, regression modelling in this case. So the idea is it's quite a simple diagram I've got here, but you take your outcome of interest, which here is 30-day mortality, and you try and associate it to an exposure. So you have an exposure group and a certain exposure that group is experiencing, and you are trying to mine for an association there. By the way, challenge for the audience, it's a fun visualization challenge, trying to think of an icon for mortality that's sensitive. I will shamefully admit this was a skull and crossbones at a certain point, and then we've migrated through a coffin, and now we've ended up on here. I think it's a surprising challenge to try and come up with that. Anyway, so one of the powers of statistical modeling is that it allows you to build in other factors that might impact on the outcome that you're looking at, allows you to control for them. So we introduced these confounders, and this was mentioned in the previous talk as well. And these might relate to patient demography or calendar type variables or sort of the health state of the hospital at the time of the event. So by building these in, you can essentially statistically isolate the association, given that you are well covered in terms of what confounders you've built into the analysis. You can then posit that what the model has derived as the association between the exposure of interest is a real effect. And just for your reference, I've left a citation at the bottom here. This is the sort of original article where this first bit of work was done, which drove the headline before. This was done in 2022, and it's not my work, to be clear. But this is where I was coming in. This is the context of where I was coming in. I was aware of this work. And the story goes that I had a couple of spare weeks after finishing off some projects, and there was some interest in our system to look at ED pressures. So I thought I'd have a look at this analysis in a bit more depth. And by doing that, I actually reached out to one of our trusts in our system, and I got in contact with James Cameron, who heads up the emergency department in one of our biggest hospital sites. And it was, like a match made in heaven. He was already fully familiar with this bit of analysis. He loved it. He thought it was great. And he had his own ideas about things that could be performed in terms of further work. And that really centered around shifting that exposure group from all ED admitted patients to specifically medical boarders. Now, personally, I hadn't heard of this term boarding. So I'm going to give a bit of a background on it. So there are many stages that patients go through when they attend an A&E, and should a decision to admit be made, there's often a delay. Essentially, they start queuing for a bed in the acutes, and that time between the decision to admit and the admission to the ward is called the boarding time. Now, there are cubicles in emergency departments that are designed to take these patients, but they are often fully occupied. And so what happens is these queues start spilling over, and these patients can end up being positioned in corridors, escalation areas, and in some cases in areas where there are X-ray machines and things that are important diagnostic tools. So not only are these environments inferior for the clinical care of those patients, but it also diverts resources from other patients who require emergency assistance. And essentially, you can imagine if you've got the system where you've got patients queuing in spaces they're not going to be, just flow in general is going to be impacted. Now, medical patients are a specific cohort, and just to define them, those are patients that are admitted to the general internal medical specialties and the geriatric medical specialties. And they cover about 2/3 of all ED admissions. But when you slice their pie by how much time they wait, they actually wait proportionally longer. They account for just over 80% of all the ED boarding time is incurred by medical patients. So with that sort of background, our study aimed to understand and quantify the impacts of medical patient boarding in 6 indicators of patient harm. So we talked about mortality earlier. We actually expanded our outcome measures across 6 different indicators, and I'll explain those shortly. With the hypothesis that, as well as direct impacts due to the delay in boarding that patients will incur, there are indirect impacts on other patients requiring emergency assistance. And with all our bits of analysis, there's a sort of overarching aim that we want to increase visibility on this issue, help build a shared understanding, and provoke some meaningful change. So going back to my sort of diagram of a statistical model, I'm going to show you how my diagram looks and how it differs. I've grayed out some of the elements here to try and keep it simple, but I'll be filling them in as we go. So starting with we had the same outcome that was in the first article, which is that 30-day mortality rate. The only thing that's really changed so far is that we've sort of shifted that exposure group. Hopefully you've understood that now, that we're not looking now at all ED admitted patients. We are actually specifically looking at medical boarding patients, and the exposure is no longer the full ED wait time. It's actually the boarding time, the time spent waiting for a bed. Now, I've drawn this out in a kind of left to right pathway. If you consider this to be like a pathway through the ED, we can talk about those impacts directly as being sort of downstream of the boarding, which sort of sits in the middle there. And you can think about impacts backwards as being upstream. So filling in the rest of the picture, the other downstream impacts that we considered were the 30-day readmission rate and the medical length of stay. So given that we accept that there's going to be harm in terms of 30-day mortality, logic would kind of give over that potentially there'll be harms that will be manifested in longer medical stays and higher readmission rates. And then upstream from the boarding queue, we wanted to understand if ED wait times were going to be impacted by high levels of boarding, and if ambulance handover times also would be impacted. And then if you can imagine that you've got large ambulance handover queues, that therefore maybe ambulance response times were also going to be impacted. So those are our sort of 6 impact measures that we were looking at. And one last bit of nomenclature, or one last thing I want to add to the diagram, hopefully it's not too complicated, is just sort of a subtle point. So starting with the downstream impacts. So I've sort of said this already, but that's the exposure there is the time waiting for a bed. So that is the delay and its direct impact on those patients that are delayed. However, it's a little bit different when you think about the upstream impacts. Your handover time causally isn't going to be impacted by how much time you might then wait after you've been handed over in the emergency department. So, but boarding still impacts this, right? So these are actually impacted by the level of crowding and not by the delay itself. So we've got a slightly different exposure for our upstream impacts, which is the boarding queue, essentially, at the time of your event, be that your ED arrival or your ambulance handover or response. Okay, so that's the sort of model framework. I spoke briefly about confounding variables, so I'll just want to quickly cover which variables that we accounted for in our analysis. So we had some patient demography, so age, sex, and deprivation were included, as well as a comorbidity score, and activity history, and that was in terms of how many A&E attends the patients had in the last 60 days. We also included temporal variables, so the event time and month, and whether it occurred on a weekend, where those events are the ambulance dispatches or handovers or the ED attendants. And then to those, we also had outcome-specific covariates. So depending on whether or not your outcome was delay-mediated or crowding-mediated, we had these specific confounders to help control and further isolate the impact of interest. So in the delay-mediated models, we included the time to DTA. So that's all the time up until and from your arrival to when the decision to admit was made. And this allows the model to be able to isolate which component of the delay is more explanatory of the outcomes. And then also patients with no criteria to reside at that trust site at the time of admission. So, and this is sort of subtle, but I think this is an important thing when we were sort of doing the problem structuring here. If you've got high levels of no criteria to reside, which is when patients are medically fit for discharge, but they need sort of downstream care and that can't be procured for whatever reason, they end up residing in the acute beds, essentially blocking them from new patients coming in, which if you sort of zoom out and look at it from a system level, that's going to be increasing your length of stay, and it's also going to be increasing your admission time. So we wanted to make sure we built that into the model to allow it to control for any exit block effects that might be increasing both our exposure and our outcome as a kind of hidden variable. And then for the crowding mediated outcomes, we included all other occupancy in the ED, excluding our exposure group. And just to summarize, I actually had a slide on this and I removed it and I forgot to put it back in, but we did this over 3 sites in our system, and it's just about 2 years of data. So to summarize, I've got a big regression table here that just sort of shows the effects that we found. I don't want to list these out. I'm hopefully going to make them a bit more engaging with graphs and some dashboard stuff later on. But just to say in summary, that we found significant positive effects across all of our outcome measures. So we sort of found that signal that this boarding issue is associated with all these different measures of harm. I will point out one in particular because I think this one was particularly important for us to unearth, which I've highlighted here, which is this inpatient length of stay effect. So if you look at the exposure column on the left, this is for every 4 hours of excess boarding time, there's actually slightly over double that time then spent by those same patients in the acutes. So to give some context, on any given week in one of our hospitals, we can have many patients that board for 12 hours, and that's essentially just accounting for a whole extra bed day that's essentially failure demand. So that's a really important thing to try to unearth. So I said I'm going to show some graphs. So this is for our upstream or our crowding mediated impacts. What I've done here is I've plotted the raw data, but I've used models to standardize for all of the confounders and then left the exposure on the x-axis and displayed the outcomes on the y-axis. So if you see a positive trend, you can kind of you can glean that the increase here in the boarding queue is increasing the outcome. And as you can see, you sort of see these positive trends across the board here. One thing I will point out, because I think there's a bit of a silver lining to this cloud, it's the category 1 response. So that's on the top left panel. That's the category 1 ambulance response. There is, even though the model does tease out a significant positive association there, and you can sort of squint your eyes and probably see it, it is very minor, which is kind of, I guess, an indication that prioritization is working in those cases, so that those most serious critical cases are being responded to within targets. However, we can see just on the plot below that for category 2, that's not the case. As the boarding queue increases, the response time also increases. And these are still very serious incidents. These are sort of strokes and heart attacks and really life-impacting incidents. So it's not great news. And just to finally say that the dashed red line are the sort of targets that we're supposed to be meeting, and the black dots, which are the 90% quantiles, are supposed to be under those. So yeah, you can kind of get a picture there. And for the downstream outcomes, I've shown these as conditional effects plots. So these are kind of raw from the final models, and you can kind of see what impact they're having. And it's similarly laid out as the last chart. So you've got the exposure, which now is the boarding time in hours on the x-axis, and on the y-axis you've got the various measures of harm, be it days of inpatient stay, the 30-day readmission rate, or the 30-day mortality rate. And as you can see, again, there's a positive association there. To kind of boil out some kind of more rule of thumb kind of stats from this, we computed a number needed to harm for the mortality from our cohort study. And we found that for every about 70 patients that were delayed more than 4 hours, there was one expected excess death. So that was the sort of modeling and the results section of my talk. I'm going to move on to some of the further work we've done and how we've tried to communicate this. I think I've actually got some time to very quickly flash up this diagram. This is sort of a brainchild of James. He's been super critical to us understanding this issue, and he sort of drew out this diagram. And just to say, this isn't sort of like cited or anything. This is sort of an idea that he has, and it's this picture that he has of this cycle of harm. If you can imagine that people are being delayed in the emergency departments and then spending longer in the acutes because of it, and those delays in the acutes are then causing increasing delays sort of downstream. You can see this sort of negative feedback loop, this spiral or cycle of harm, as he calls it. So I can't talk for too much about this. I don't have that much time. But yeah, it's maybe take a screenshot of it. I think it's a fascinating way of looking at the system. So yes, so moving on from the static insights that I've just presented to you. So I'm not trying to show off here, but we are very close to acceptance on our submission for this bit of work, and I'll be very pleased to forward a link when I have it to the paper, and you can dive into all the details. And so we're really chuffed with that. We think in our team that's a great way of sharing our analysis and making sure that other people can reproduce it. However, it's not necessarily the best way of communicating your results to sort of exec level or managers or planners in your system. So we wanted to come up with a way of doing that, because we felt like we'd already done all the hard work of doing all the modeling. So I want to point back to the very first slide, which was that headline, right? And that's a good way of doing that. So we thought, well, why don't we just design a dashboard to do that, essentially, to generate these results dynamically, because we get this data live weekly. So we can just dynamically refresh those impacts. So we designed this dashboard with that in mind, trying to make this as simple as clear as possible. And it looks like this. I call it excess impacts. And the way that I've sort of done this is slightly different to that article. I had my own sort of inspirational idea. I think I'm quite pleased with this. I decided to present it as a sort of counterfactual what if style analysis. So what you'll see, so at the top, you've got the kind of standard headline, which tells you what happened in the last week. And then in the middle, you've got this column of bar charts. Now, these bar charts have each got 2 bars in them, right? And on the left is the estimated impacts based on what actually happened according to the data. And on the right is a hypothetical situation of what we would estimate would have happened, given that you were able to keep your boarding times to under 1 hour and the boarding queues to under 25% of the ED capacity. So this allows you to see what operational changes, or if you had that lever to pull, what difference that would make in terms of, for instance, if we look at, say, the third chart down, in terms of the category 2 ambulance response time, you can see that it makes a large impact in bringing you closer to the target. And so this dashboard refreshes weekly, and it's helped us basically explain these problems and make some meaningful change. So I actually probably won't talk about the deployment time. I'm looking at my time. I'm realizing I'm just about on time. So I just the last thing I want to talk about quickly is some of the operational impact that's sort of precipitated from this, which is that based off of some of this work, discussions with the hospital managers have incurred this idea that we're going to reinstate this continuous flow model, which is something that we did a few years back, but it kind of fell out of fashion. And essentially, this model shifts the admission from a pull mentality, i.e. the wards saying they're ready to take a patient, to a push mentality, where you basically tell the wards that at specific scheduled times, you will definitely receive admissions, so be ready for them. And the idea is that by doing that, you're going to alleviate the pressure at the front door, and hopefully the downstream impacts will be felt after due to the delay the reduction in delay related harm. Now, there's a bit of further work that I'm going through trying to prove that this is working. So this is all sort of hot off the press. But I'm happy to take more questions about that. I think I might be running over time, so I will just do my quick conclusion, which that this research further establishes and quantifies the association between delay, and specifically medical boarding delay, and significant patient and system harm. The deployed dashboard provides a mechanism for ongoing monitoring of these impacts, and moreover, the modelling provides a framework for hopefully measuring intervention effectiveness. So that was me. Thanks for listening, and back to you in the studio, James.
Brilliant. Thanks very much for that, Nick, and right on time as well. Fascinating presentation on the work you've been doing. I particularly like that what if analysis that you brought in towards the end. We've now got a few minutes for Q&A. Looks like in the chat, Nora has had a bit of trouble with the Q&A function, so I don't know if that's a common issue, but please feel free to put any questions in the main chat if that's the case. I think, Nick, you covered off Nasir's question about getting the link to the study already. I don't know if that's available yet or might be further down the line.
I was really hoping it was, but the third editor comments hit the email about a week and a half ago, and so I'm busily trying to get those tidied away. I think it's actually good news. Maybe I'm trying to see it with rose tinted glasses, but I think they're really keen to make sure that it's just very clear, and I think it's going to be not to pat myself on the back, but I think it's going to be quite a big, impactful bit of literature. So I think they're just really keen to make sure it's all nailed down. So I don't know what the best way of following up and giving a link out. I was hoping to have a little snazzy QR code that just takes you to it, but unfortunately, it's not quite there yet. But I mean, hopefully, when I evaluate the continuous flow, I'll be back and I'll be able to at least link it then. And I'll certainly be submitting that as an abstract next year.
Thanks, Nick. And then just on Nora's question around the comms approach as an interesting comms approach as a counterfactual. How did they land with clinician and managers as users?
Yeah, it's a great question. So I was a bit worried at first, actually. Not that long ago, people were quite risk averse to highlighting these issues, especially higher up managers would find that you can't report on these excess deaths. What if the BBC pick it up and we're all under scrutiny? So it was a little bit timorous to share it, but actually people have been really accepting of it, and they've really enjoyed how simple it is. I didn't get a chance to really show it, but there are some other dials and things that you can tweak on the dashboard that let you kind of change some of the scenarios that are going through. And I know that some of the people, what I know has happened is there are some people that have been trying to have this argument or try to put this argument forward for a long time, and they've really struggled, and they have used this in anger to try and say this, this is what's going on. And I know that it gets used for that purpose. So yeah, I would say the reception of it has been overall very positive.
That's good to hear. I am conscious of time, but I just wanted to get Stephen's question in just to finish. So if we can give us a 1 minute answer on that, maybe Nick. Do you have any thoughts on why the continuous flow approach fell out of favour first time around?
Yeah, thanks, Stephen. By the way, really enjoyed both your talks. So from my understanding, it'd be great if James was here to talk about this, because James he's been the one. I think he came up with the idea for the continuous flow, and then someone swapped his name out on the document. It was one of those things. But I think what happens is that the way he explains it is that it's not about it's a discipline, right? And the problem is the first, if you try and instill a discipline, often it only happens when you're already in a serious incident. But that's not. Obviously, you need the discipline then, but what you need to do is maintain that discipline in the quieter times. I think what he says, what happens is that when things get quieter, in a very human and nice emotional way, the managers and the planners think, oh, well, we can relax a bit. We don't have to do such intense scheduling. But then the problem is that then you end up that catches up with you. So I think that was why it sort of fell out in the first place. And also, in fairness, if you look in the literature out there have been some other systems that have implemented it, and there's mixed reports on whether or not it's effective or not, which is one of the big motivations why we want to do our own evaluation and try and give a more insight and give our word on that.
That's great. Thanks, Nick. Yeah, we're going to have to end things there, but if you have any further questions for Nick, please do contact him. You can do that via the site, I believe, but Nick also showed his contact details there.